record this. We're talking, sorry, because I think it's a good discussion for everybody to hear. So you were saying that cadaver videos really help you. I think they are, I think from a practical perspective also, Mariana, and everybody else is from my end, because I do this on a daily basis with patients. I think the cadaver videos are also really just going right to the point without using too much complicated language of what exactly, which little point you're talking about on the body, you know, visually. I think that's very helpful. Is that also what your experience is a little bit?
Yeah, because, well, you know, using the booklet that you created, and even watching the videos when you're in class teaching, they're helpful. But the actual cadaver video, like you said, dives deep right into it, and it shows you, you know, what it would look like inside of us, instead of us trying to kind of visualize it in a way. So when I was labeling it, it made a lot more sense, because it's like, oh, well, you know, this connects to this, and, you know, being able to see it live makes a lot more sense, and being able to recognize it, you know, when we move on into the future, or like if our career were to depend on it, I feel like it's a lot better for us to already just kind of see it like live.
Well, that's how I feel. I mean, I was teaching, you know, this for a while, and one time I remember I was teaching one of my children, and I have that too a little, where it's very hard for me to create a picture with words alone, and I space it out, and then it's like if I read an anatomy book, it's really difficult to focus on that and not sort of fall asleep over it, and not space out over it. But if I go right to the point, and again, the visual medium is so much easier to understand for so many of us. And it's a good bridge to then, depending on what you do, some of us become, you know, physical therapists, some of us go to nursing, but it's good to understand how to touch, or how to visualize, how to then palpate that also in a patient, for example. And, you know, when you work on a patient, for example, nobody gives a crap if you know exactly what attachment site's called what. You know, that's not that relevant anymore at that point.
Yeah, exactly.
You know, so I'm glad you're finding those helpful, because I was a little shy of first putting him up, because yeah, there's, you know, it's cadaver stuff, so it's like a little gross. But you know, it's not that's why I have multiple things to go into, you know, explaining it. There's the description, the pictures, then the cadaver videos, the in-class, and then the other videos as well. Did you find the in-class videos more helpful in this section than the lecture videos, or do you have preference on that, or not really?
I usually do both. So I watch your lecture first with the booklet, and then when I'm doing the coloring, I watch the shorter ones where you're not in class and you're just kind of describing it yourself. But I rewatch them twice. I rewatch both of those videos twice. So I always watch both of them regardless. And even when I'm doing the coloring part, I watch that one. And then all the quiz ones you do, I watch all of those too right before I do the quiz as well. Because they're really helpful, because you're not just giving out the answer, you're helping the class, you know, find the answer and why it is that answer. And it sticks a lot more to me than just trying to be like, oh, it's A, oh, it's B, it's moving on. You know, you kind of stay there and you describe it, you help the class, you know, find the answer too. And I think that's really great, because it shows us that, well, one, it would have been great to be in the class with you instead of doing this, you know, Zoom live, but it's really helpful when I'm doing the quizzes too, and it helps me understand it a lot better.
I'm really glad you're saying that, because it took me a long time to actually just even think about putting those in, because the last few years, couple semesters at least of teaching in class, I really focused more on going through the questions, because I'm asking the class to do it before class. It's sort of my way of tricking the class into reading a book before we get to the classroom. And so it just kind of translated onto that online environment. So I'm glad that helps. And it probably also helps them understand the material better as a whole, right? Is that, you know, not just getting a good grade.
Yeah, okay. No, yeah, definitely. So like when you do these test reviews, everything already makes sense. You know, like to me, everything just starts connecting the way that you would describe the body parts. And you're like, oh, okay, this already connects to this part of the body, that connects to that. It's this movement, this is the origin, this is the insertion, this is the action.
Yeah, you know, and that's a good segue. Hi, everybody else coming into the class. We were just starting to talk about it, what makes sense, what's a little, how we learn. but I think this is a great segue right into talking a little bit about the last two chapters that we're having here, the upper and the lower extremity muscles. I know the lower extremities come this week, but I also know the test is open Friday, so I want to go through both of those today, and then we can go again over it next week if we want to, but I want to give you the overview that, oh, hold on, I'm in the wrong section. I want to give you the overview a little bit more today, so you understand the big picture as well as the little detailed muscle parts. So when it comes to the test, and again, if you have anything, questions or comments or anything, please butt in, interrupt me. Do not feel bad about that. Don't worry about sending a chat or something because I'm not looking at that. So just interrupt me, and that way we can create a conversation also. So don't just think I have to be lecturing alone. And if you have a question, guess what? Everybody else has the question too, most likely, and just doesn't want to ask it. So let me first go again into the tab of the test review. You can see my stuff. Is that correct? You can see my test review tab?
Yes.
Good. Now let me actually do student view. It doesn't matter actually on this one, but and so here I want you to print out this test term list if you have not done that before you take the test. In case you cannot print it, don't have a printer, at least download it somewhere and have it handy, because all the terms for the test come from this list. These are all the terms that are in the individual chapters just on one list. So I think that's very important, because you do not need to worry about there being any term that's not on that list. And so, you know, that way you can also maybe minimize, you know, that a little bit, that the anxiety that there's infinite amount of terms, because there is, it's anatomy, it's crazy. But I'm not pulling from anywhere other than that list. Then a second thing I will do before you take the test, at least one time, I would go through these review videos and with the list and see, identify the term, you know, that you see on that, on the real model that I'm going to use for the test. I think one time, or at least, you know, if it doesn't speak to you at all, then drop it, don't worry about it. But I think you should give it a chance, because the more we review that stuff, the easier it's going to be. And then the last thing that I would also do is, don't print that out necessarily. It might take a lot of ink, but if you can, you know, don't worry about it, go for it. But I would go to that at least and have it be in an electronic format and try to find every term that you can that is on these pictures. So not all the terms on the list are on the pictures. Oops, sorry about that. But most of those terms are on that list. All right, so any questions to that part as a test prep goes? No? Good. Then what we should do is go a little bit through the material, I think, that is the muscles of the extremities. And if you have questions to the previous stuff, what we discussed yesterday or other weeks, that musculoskeletal stuff, please speak up and we can go and hold on. We can go and go through those questions also. All right. Let's see. We have, these are the PowerPoints that we use for the, no, I want to do the upper extremity, not the lower extremity. Hold on. Why is this? Oh, you see, you're seeing a person with muscles, right?
Yes.
Yes.
Okay, so you see the same I see, so that's perfect. So when I look at the muscles, oh, one thing I wanted to point out before I forget, when we were talking about the cadaver videos, that was with Mariano. I wanted to, you know, you were saying also for later on, maybe after the class, if you ever want to go back to these videos, on half these videos, I suggest go into the pro tips of week 7 or week 8 or even week 6, I think, here in the extremities. And then here under the pro tips, I have cadaver video clips. And if you click here, it gets you a whole list of the Dropbox of the videos that I embedded into the main points. And so here you get like all the videos are listed up, all these little clips that are in there. And I have the name behind it, but then I also have a labeling system behind it. LE is lower extremity, and UE. That way it's ordered properly. And then I have a label, a catalog where everything's listed. So that's a link that's for public. That's also available to you after the course when you don't have access to Canvas no more. But if you want that, I want to make sure you pull it out and have that link handy after you can't go into Canvas anymore. But I suggest these. If you go for physical therapy or anything like that, I suggest these videos are really, really helpful throughout your career, probably, or at least throughout my career, which has been spanning for about 20 years now. So it's you got to always review those pieces, otherwise you forget. All right, but that's somewhat FYI. You don't have to do that. So let's go now into the upper extremities. And when I look at the upper extremities, I sort of, again, I like to not just have a list of muscles, but I like to have groupings of functionality. And so when I look at the upper extremities, I should pull up a skeleton, but that's all right. Here we can do that part here. Let's make it a little smaller. When I start with the upper extremity, I start, here where the spine is, and then the scapula comes out in the back. Clavicle holds the scapula backward, so it's in the back part of the body, not rounding forward all the time. So that's really what the clavicle does as one of the main functions biomechanically when we look at movement. And then from there, we have the arm coming out, the humerus coming out of the scapula, the shoulder blade. And so when we look at muscles, we want to have a few groups up here. We want to have one group that holds the shoulder blade into the trunk. And so those muscles will be attached to the shoulder blade and somewhere to the trunk. And if you visualize how would you need to organize that? You can probably have something attaching in the back to the trunk. That would be your levator scapula here, the shoulder anchors here, and then down here, the rhomboids further down, which is these down here, right in here. So let's go back to this picture here, though that's easier to understand the anatomy. And so these are here going in. So the levator scapula just pulls the shoulder blade right into the neck. And then the rhomboids go more into thoracic spine and pull it more medially that way. So that's what those are. And then overlaying that, we have the trapezius. But the trapezius is the superficial muscle. So that's less an anchoring muscle, but more of a moving muscle. The anchoring muscle are usually the deeper muscles. And then you can have the next one that anchors the shoulder blade really strongly into the chest is the serratus anterior. And it's an interesting word. Serratus comes from the serrated knife. So you see here these little things sticking out. Or if you look here on this goofy looking old man, these little knife-looking, serrated knife-looking things, like a bread knife is a serrated knife. And that's the name for it. But when you look at the muscle itself, it's by mechanical functioning, it's attached on the shoulder blade towards the spine, so only underneath of the shoulder blade, and anchors into the rib cage. And so he pulls that shoulder blade onto the rib cage, not letting the upper extremity just hang down and loose. So that's a great muscle, right, to have to anchor that shoulder blade. So you got one in the back, one on the sort of side pulling it in, and then we got one in the front, and that's the pectoralis minor, and that goes from the coracoid process, which is here, which is the front of the shoulder blade. It's still the shoulder blade, and pulls it forward onto the chest. And so then that anchors that shoulder blade onto the chest properly. And see, that's when I would look at muscles from a biomechanical function when people come in with pain and other, or performance problems too. And then when I look at it that way, I can sort of see you know, those postural things that we did in the posture exercise, but more from a muscle function perspective. So it slowly guides me into where there might be problems that then the person has pain syndromes or not from it. Because if the shoulder blade doesn't sit right on the chest, you're going to have problems in the shoulder somewhere. It's going to wear out because you're not working it ideally, sort of ideal posturally speaking. All right, so that's the first set of muscles that I like to discuss in that upper extremity. And then the second one is the rotator cuff muscles. And those are muscles that are attached on the shoulder blade and then on the humerus, on the top of the humerus. And they pull the humerus into the shoulder blade. They hold the humerus in. They move it a little bit, but most of what their work is to hold it in. And we have three on the back. We have supraspinatus, infraspinatus, and the little tiny sucker here, the teres minor. And then we got one on the front, there's the subscapularis muscle. So those are those. If you look at rotator cuff injuries, problems, usually supraspinatus is impacted because the outside part, this part here that goes into the, when we look here, that part here that goes into the greater tubercle of the humerus is not well vascularized. That doesn't have great blood supply. So it becomes a little brittle with age or with overusing it. Overusing is like, you know, like somebody swimming a lot and doing crawl. You see that, you can see that, and always goes to the extremity motion. That can overuse a joint, the shoulder joint, for example, over time. Or of course you can have injuries. And so from there then, so we have the shoulder anchors, putting the shoulder blade into the chest, the arm movers, or no, the arm, holding the arm into the body muscles, the rotator cuffs. Oh, and when you see that word sits, S-I-T-I-S, here, this word, it stands for supraspinatus, infraspinatus, teres minor, and subscapularis. So it's just the first letter of all the muscles combined. Seems to be a common acronym. That's why I put it there. So people, as a remembering thing for people. Good. And then we have arm movers, and those are muscles that move the arm around. They're in the front, on the side, and in the back, actually in the back going down. So we got the pec minors in the front. You can visualize that, how that can move their arm around in the front plane. We got the outside is the deltoid that moves the arm also in the front side, but also back plane a little bit. So it's got multiple motion planes. So if you want to train it, you go like that kind of stuff. And then we got in the back plane, we got the latissimus dorsi, and you can see that was, you know, the Michael Phelps picture is extreme, where you can see how big that is, because you can visualize how when that arm is stretched out forward, extended, and then you pull it back, like in a crawling motion, that muscle is doing a lot of that pulling. And so that's the back plane. And then we got a few smaller players. We got the coracobrachialis that's attached at the coracle, named by its attachments, coracoid processes going down to the arm, the brachius. Everything brachial is upper arm, humeral area. That's really good to remember that, because you can sort of place the muscles if you see a name. And the teres major is sort of the small cousin of the latissimus dorsi, attached to the shoulder blade, going into the same direction and placing off the sort of the underarm part of where the latissimus dorsi goes. The teres minor is attached in, it goes to the outside, to this part. So it's from that perspective a different muscle. It just has the same name because it's small and it's in the same place. And then, yeah, sometimes the same name muscles like the pectoralis, also the minor and the major, don't do the same thing. Sometimes they totally do the same thing. It's just there, one is bigger and one is smaller. But the major minor refers to size, not to functionality. And then from there, we got the elbow movers. And the elbow movers are attached up on the arm, in the upper arm, the humeral area, because they go from there or from here, the scapula, the biceps brachii actually has a little attachment to the scapula too. Well, actually, no, all of it is to the scapula. One is to the front, one is to the inside. And then these elbow movers, go to the forearm somehow or another. Most of them on the elbow side, the proximal side, as in the biceps brachii, the brachialis, which is underneath the biceps brachii. When you take the biceps brachii, you see it right there laying underneath. So it starts about mid-shaft Actually, it's interesting. It starts pretty much where the deltoid goes in, then coming from the outside here to the outside, the shoulder pocket muscle, I call it. And then the brachialis also goes here straight to the elbow and really forcefully helps to bring the arm up and flexes the elbow. And then we have one more player there, and that's a weird one. It's called the brachioradialis, because it goes from the brachial, the humerus, whenever brachio again is humerus, to the tip of the radius. And when we look at the radius, we always know the radius goes to the thumb side. Radius goes to the thumb side. Ulna goes to the pinky side. Keep that in mind. That is very helpful. And so the brachioradialis actually helps flex the elbow, but emphasizes a bit more of the pulling from the forearm here. And so when you look at then all those elbow flexors that bend the elbow, or, those are the elbow flexors, they are all attached in the front of the arm and then go into the forearm somewhere here or further down here. And when they collectively contract, the brachialis is actually the main movers, and the biceps and the brachioradialis help them continue or do the movement and pull from different planes to assure the movement is happening properly, and is stabilized for sure too. And then the elbow extensors, the other movers that do the opposite function. And it's interesting, you always have an agonist that was one motion, and then you have an antagonist that does the opposite motion. And neurologically, the one that doesn't contract in that relationship has to relax neurologically, because if it doesn't, we do not have motion at the joint. And so that's kind of an interesting, it's a little higher neurological concept, but it's, it's not as difficult to understand. It makes a lot of sense. It's called Sharingtons Law. And so if you pick that up, that's great. If you have more questions on that, we can talk offline too, or after class. It's very interesting stuff. Anyway, the extensors of the elbow are attached in the back of the arm, which makes sense. The tip of the elbow is here, the olecranon process. When they contract, they straighten out the arm. That's what they do. Those muscles are the triceps brachii. So in the front, you have the biceps. Bi means two heads, ceps means head, and tri means three. So in the back, you have the triceps. The front one is the biceps brachii and the brachialis sort of combined that in the back create the triceps. It's just the back motion is a little bit more straightforward than the front motion, the flexion motion. All right, now that, again, if you have any questions, speak up, interrupt me. I'm going quite fast because it's just review. But I then want to go to the front forearm muscles. Those is where we get challenges. I think most likely you probably agree with me that this is not an easy topic here. But let's try to narrow it down. And again, if you have questions here, interrupt me to clarify. This is one that for most students is the hardest to grasp first. And that includes myself too. All right, when we look at the forearm, we're going to look at muscles that are in the front of the forearm, and then also muscles that are in the back of the forearm. First, let's go for the front of the forearm muscles, because those are the more complex ones, the way we analyze them. The forearm flexors, or the wrist flexors, it's called, really, because they work the wrist and then the fingers. Those are stronger than the extensors. When you hold the back by curling your fingers, that's a flexion motion. Your hands are much stronger in that position than if you extend it, you couldn't hold the back that way. So the forearm muscles are much bigger and much more bulky than the back forearm muscles, the front forearm muscles than the back forearm muscles. All right. When we look at it further, we're going to see that all not all, but the ones we study, there's the top, we study the top layer, and then underneath the top layer, we have deeper layers. And in the front part, in the anterior portion of the forearm, those then become finger movers. So the finger movers and the wrist movers are both here and in the forearm. And so the flexors that we study, the superficial, the first layer, those muscles are all attached to the medial epicondyle, and a little more depending on the book you read. But that's a very good common starting point. And then they reach towards the forearm into the wrist. And then the thumb side is here. See this big bulky muscle here? That's the brachioradialis. That muscle on the models is a really good point of reflection between the forearm flexors and the back arm extensor muscles. I'll show you that again when we do a little bit of the quizzy stuff. So when we look at the forearm front muscles, the flexors, we got four that we are interested in. We got one that's called the pronator teres, one that's called the flexor carpi radialis. Look at that name. Flexor is the function. What does it do? Carpi is where does it do that function? So flexion is bending the wrist forward. And then carpi is the carpals. That refers to wrist. And then radialis refers to which bone does it go parallel to, and more or less, you know. And this is more or less parallel to the radius. And the way we understand it, that this muscle reaches towards the thumb side. That's why radius, thumb, that's connected. And then the next muscle is the palmaris longus. And then the fourth muscle is the flexor carpi ulnaris. And again, that muscle is like the flexor carpi radialis, except it goes toward parallel to the ulna. And that's why it's called ulnaris, and that's towards the pinky. All right, good. So then the other thing we need to understand here is in the forearm, we have two more motions. We have flexion extensions, and we also have pronation supination. We talked about that in the joint chapter. So if you remember, don't remember that, go back to that and refresh your that. But pronation is palm down, supination is palm up. And I remember that by supination, I can hold a bowl of soup in my hand when it is supinated. I know it's quite silly, but you know, that's usually the ones that stick the longest and the best. So don't feel weird about that. Anyway, a supinator is bringing the palm up, but pronator is bringing the palm down. And a big, most important pronator we have up here called the pronator teres. We have a second one down in here, we'll call the pronator quadratus. We do not study that. But the big one here is the pronator teres. And so that's that word pronator, is by what function does it do? So that's the first one that we studied that comes out here, and it pretty much crosses over from the medial epicondyle on the ulnar side, which is the medial, the pinky side. You always refer these things by an anatomical position, which is palm forward. And then it goes diagonally onto the radius and pulls on the radius. And if you can visualize that, when it pulls on the radius, it brings the thumb towards the inside, and that means it goes, you bring the palm downward. And so that's, and the reason why that muscle is so important is because you got a nerve going through it, and that gets pinched, and it mimics carpal tunnel syndrome, because when we type, we have to hold the palms down. So this muscle is always active. And this is why in the ergonomic evaluation, I have that picture of a keyboard that's a little bent. And so if you have problems with your carpals, then that might be a helping little ergonomic aid because of that, because then the pronator is not so active. I know I'm going a little elaborate on those, but those are always a challenge. And so I want to make sure you understand those muscles. Then the flexor carpi radialis, I already told you, goes flexes the wrist, the carpal, and goes to the thumb side. So that's easy. And then the palmaris longus is a long muscle, long muscle that goes into the palm of the hand. If you actually bring your, if you bring your fingers like that up like that, you can see a tendon in here. Most of you, some of you don't have it, 10% don't have it. But if you see a tendon here sticking up, that's the tendon of the palmaris longus muscle. So that muscle basically flexes, you know, the hand that way as a general pull. It's not as specific as the others. And the reason why I can see that tendon is because you have this wrist thing here called the flexor retinaculum, and that's an area where we often, when we have carpal tunnel surgery, they cut this because it frees up the nerve that is irritated. But that muscle, and that is a challenging, be careful, do that surgery, make sure you get second opinions before you do that one. But that muscle goes above that, and that's why you can see that tendon, and it's now pulled underneath that big old retinaculum is a ligament that holds things together. Anyway, and then at the last muscle here we have the flexor carpi ulnaris, which flexes the wrist on the ulnar side, on the pinky side. So those are the 4 muscles in the forearm that I want you to know for the test. And an easy way to remember is if you take your hand and the opposite arm, obviously, and you pull the web of the thumb side onto that medial epicondyle and your fingers lay on the forearm, you can sort of have each finger be one of those 4 muscles. And then we learned it as an acronym for PF, which is the first letter of each muscle. And then that's how it kind of got, you know, burned into the brain cells of what does that mean as a sort of helping aid. All right, good. Any questions on that one? Please shoot up if you do, or speak up if you do, sorry. That clear? You guys understand that?
Yes.
Oh, good. You guys are good, huh? Excellent. Good. Then we can move on. Then we have the wrist extensors, and the wrist extensors are similar in some ways than the wrist flexors. We have a carpi ulnaris, we have a carpi radialis, again, same thing. On the ulnar side, on the radius side, what we have here is the common origin of these muscles is not the medial epicondyle, it's the lateral epicondyle. So they come from the outside elbow and reach over to the top of the hand. And then the third one here we learn on the top. We only learned 3 for at this point, and that's the extensor digitorum, and that extends the fingers. The ones that are in the forearm, the flexors of the finger, are deeper. See here, extensor digitorum. They're laying deeper, not in the first. Oh wait, flexors, flexor digitorum. We can't. Now see, it's not even labeled here. Yeah, flexor digitorum here. It's deeper. And so we don't study that on the flexor side. But again, that goes back together how the flexors are stronger than the extensors. All right, good. If there's no questions on that, let me just briefly run through the lower extremities. Can you see the lower extremity pictures? Anybody?
Yes.
Good.
Yep.
So there we go from the hip down to the feet. And we have a similar sort of setup, but some things obviously are different because the lower extremities have a little bit of different functionality than the uppers. They're not as flexible. They're much more stable, but they have to carry the weight from the trunk down to the feet or down into the legs. And so the hip, one muscle group we have that we look at is a deep one. It's the lateral rotator group. And so the one we studied there is the piriformis, and that muscle is a deep muscle that goes from the sacrum out to the outside the greater trochanter. Is similar in that way to a rotator cuff muscle because those also rotate the arm in and out, and the lateral rotators are the ones that do it on the hip in the backside. And there's multiple muscles here. There is all of these, like here you can read them, see them. But the one that we study is the piriformis. That's the main one. And you can see, for example, if somebody lays face up and you see that contracted too heavily on one side, that side of the foot turns outward. And so that's the function you get from that muscle is sort of the foot turning out happens up here in the hip. The other thing that's interesting about the piriformis is that the big nerve that goes into the thigh and the leg, the calf, is the sciatic nerve, and that goes through the piriformis, and that can get pinched by an hyperactive piriformis. And the piriformis can often be hyperactive because it's what it does. You can visualize the spine is like, and then the head on top of the spine. It's like you can hold the broom upside down and you have to balance it. That's what the piriformis does for the spine. It has to balance the spine going up and down. And so it can be very, very active and depends on what we do as people. So that's a lateral rotator group as a function goes. And then we have the hip abductor group. Abduction is the motion of bringing an extremity outward. So either an arm or a leg. And so here is a leg, obviously. And so the abductor group brings the hip outward. So those muscles are going to be attached here and then in the front more also, a little in the back, a little in the front, and pulled to the outside into a band called the iliotibial tract, and also into the big bump here, which is the greater trochanter. And what they do is they contract and pull the leg, and when they pull, they pull up here into this area, the leg comes outward. and that's abduction. So that's the gluteus muscles, the gluteus medius, minimus. They're very similar. Medius is on top, the bigger one, and then the minimus is in the front. The minimus also helps rotate the hip forward a little bit. So that's actually a function that it also does. We just talked about the posterior rotator. The minimus helps the anterior rotation a little bit. I didn't list it down here, but that's a minor function there. And then we also have the gluteus maximus. That's the big muscle laying on top. So here you actually have a cross section of the medius here on the side. And then as you get into the sacral area, you got the maximus going on. And that goes from that area and reaches into the back of the thigh in here, and then goes down into the iliotibial band on the outside. And then that's from the back side, and then from the front side we have called the tensor fasciae lata muscle, and that muscle is named because this white band here used to be called the fasciae lata. Fascia is a thick, tight band, and lata means white, and so the name of the muscle still stands. So the tensor fasciae lata is up here, and it reaches into the IT band in the front. And if you can visualize that, when they contract, they pull that leg outward as well. The glute max also extends the leg. That's of course another. When you go hike a lot, you get a really big, or squat. It's the same thing. Also, you develop the glute well. One other thing that I usually mention with the TFL or the IT band is people that roll it out, or I start mentioning that, because it's controversial. Is it good if you have a tight IT band because you like to run or so? These get often very tight. Is it good to roll that out with a foam roller or not? And my basic philosophy is if you roll down here, you're not going to do nothing. You're not going to squeeze any tissue and squeeze any blood out and relax any tissue, because this is a ligament, a very strong avascular, cable, a steel cable, so to speak, a flat steel cable. But if you work the muscle and you foam roll the muscle up here, which is what this guy does down here, then you're effective because you work the muscle tissue and you squeeze muscle, by doing the rolling, you squeeze the blood out of the muscle tissue. And if your muscle is a little too much contracted or much too much contracted, the blood in there becomes static and it doesn't move because it can't go anywhere if the muscle tries to hold on and contracts. And so by squeezing that muscle, you squeeze the blood out, you relax the muscle also neurologically, but you bring new blood in, and that really helps the muscle, and that helps, feed the IT band because the muscle tenses it. So if the muscle is more relaxed, you get less tense IT band. Anyway, blah, 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 a lot of talking. Sorry about that. Hope that's somewhat helpful. You can always stop me. I know I'm a blabbermouth. So then from there, we have the muscles that pull the leg to the outside. We have the muscles that pull the leg, that rotate the leg. We talked a little bit about that glute max that also pulls the leg backwards. Now we also have to go forward, and that's the hip flexor groups. And the one we studied there is the iliopsoas. And the iliopsoas is actually two muscles. It's the psoas major and minor, but no, actually really the major. The minor is just a small sliver that we don't really worry about studying. So there is a second one. When you see a major, you always know there is a minor, or even a maximus, medius, minimus in the glutes. So you kind of know if you have to mention one is bigger than the other, there's going to be more to that, either one more or two more. But psoas major is the one that goes from the spine into the inner thigh, and then the iliacus is the second one of the iliopsoas, and it goes from the inside of the fossa of the ilium, the hip goes into the inner thigh, and it pulls the thigh forward when it contracts. This muscle is often a problem because we sit all the time and it's always contracted, and so that can be giving you issues. And I often say it in class, the psoas gives you a sore ass because it reaches back into the lower part of the low back, and so it can give you problems in the low back that you don't necessarily know are coming from excessive sitting in reality, or something else, but a problem in the psoas or the iliopsoas together. And so what you can do is a lunge stretch, for example, that kind of helps. You have to make sure to pull that part of the hip in a little bit so you really feel a stretch in the front. I have one that's tight and it gives me trouble, and I let the leg hang off the side of the bed, and that kind of stretches it out passively, or lay on the side of the bed, on the side of that opposite side of the body, and pull the foot backwards, and really the foot that's not touching the bed, that's free, back with my other hand, and really stretch it out that way. So those are things that can be done. It's very often a problem. All right, and then from there, we go right into the knee workers. And the knee basically has to do flexion, extension. Flexion is the hamstrings, the ones in the back, that's bending the knee. And then extension is forward. Extending the knee is straightening it out. These muscles are the biggest one. They're very massive. They're all attached, most of them, no. 2 of the 4 are attached in the back of the thigh and reach forward, go into the knee. One's attached on the bone itself that goes then into the knee. That's the intermedius, vastus intermedius. And then the last one, the rectus femoris, is actually attached on top, up here. So it spans 2 joints. It goes to the hip joint and the knee joint, and it goes to the knee. So the rectus femoris muscle, the top layer, often works together with the iliopsoas by also flexing, bringing the leg upward, because it's attached up here. It can work on this joint as well, not just the knee joint. Anyway, that's for that, I think. Very cool muscle group. Anti-gravity muscles. You have that in your injury prevention. Why are squatting muscles tender? Because when we work them. Why is squatting so important? Because the anti-gravity muscles pull us up. They make us be able to stand upright. If we don't have those functioning, if we don't have those joint straighteners functioning, we're going to sit on the floor and can't get up. So it's kind of important. Anyway, from there, we have one muscle that's a superficial, the sartorius, that does multiple functions. It's not named as a talar muscle, and it's a sliver of muscle on top here. So it's a superficial one. So it just does a lot of movement or guides movement that other muscles help with. And this, all that movement here on action, this is one of those where it's like, that's really complicated. It's really just basically means you bring the leg to the opposite knee. That's really what that motion means. And so if you visualize that, you're all good with that. And you can see that it's attached on the outside, the tip of the hip, the ASIS, and it goes to the inside of the knee. This is called the pes anserin because multiple muscles come in here, namely the medial hamstring, and then also one of the adductors, the gracilis, which we'll talk in a sec. And if you can visualize that, if he pulls from here and brings, it does that motion, it brings that leg up to the opposite knee. And so I much rather have you visualize the motion that way versus knowing the words. That's one reason why I don't test you on the action at all. I only test you on naming the muscle because I want you to functionally understand these things as much as you can. Which brings me to the adductor muscles, which are the muscles that bring the thigh medially, adduction, as in adding the thighs or the arms to the body. And those are muscles that are medial. And so we got a whole bunch of them. Most of them are called adductor something. And then one is called the gracilis, one's called the pectineus. Pectineus is all on the way on top, and no, where is it? Even on this side it is, so it's even higher up here. And then the gracilis is the one that goes down to that pes anserin, medial. Up here, some of the adductors are attached in the front by the pubic bone, and some are the hip sit bone in the back. You could see it here really well visualized. And so then you have a little pulling into the back and a little into the front. These muscles are really important. Like I have one football guy, McCaffrey, Christian McCaffrey, and I think he still plays. Maybe he's injured. But he's not a big guy, but he zigzags through that field as a receiver guy, and he's really fast and good. One time he had most touchdowns in a season. And these were the ones I had to work on him, these muscles, and stimulate them. Or an old 90-year-old I had, and she couldn't walk. She had a walker, and she came in, and actually it ended up being the gracilis that was giving her grief, so she couldn't walk right. Because it just hurt too much. And once we worked at it, it was not there, and she could walk right without a walker. That was kind of cool. Anyway, that's the motion at the femur. So we got bringing it up as inflection, bringing it back, extension to the outside and to the inside. That's about what we're going to do up there. And a knee is just bending and flexing, and ankle then is mostly down and up, a little bit inside, outside, toe out, toe in. That's where you twist your ankle. But when we look at the musculature there, we got a top one in the back called the plantar flexor groups, also known as the triceps surae. Tri means three. When we go further and understand the muscles, the way we kind of describe them individually, we have two gastrocnemius on the side. You can see those in like bicyclists or runners too. They stick out. And then deep underneath, we have a soleus. That muscle is part of that triceps surae because together, all of them go into the heel, the back of the heel. So that's why it's important to do these kind of stretches, because these muscles are really strongly pushing the foot into the ground, which is, again, an anti-gravity motion. So they're important. So that's the top layer in the calf. And then what we do in the calf, we go and take that away. And then we look at three compartments. We look one in the front, right here, one on the side, lateral, and then one in the back, posterior. The front compartment pulls the foot and the toes and extends all of that, brings it up. But yeah, it's called extensors here. You see you have an extensor digitorum, extensor hallucis. You often differentiate in the foot the big toe from the rest of the toes. In the hand, it's like the thumb too, but it's more the opposing function. Here, it's more like the toe has to have a stronger pushing down motion and also pulling up, has to be individually working like more individualized, because it helps us with the ambulation so much, with the walking and running. Anyway, so that's, you have extensors on the top of the foot, and then on the bottom, deep in the back, you have the flexors that pull the toes and the big toe downward. And so this is where you take the gastroc and the soleus away, and then underneath it, you got these muscles. And then the third muscle you both have in the back and in the front are the tibialis posterior and the tibialis anterior, and they are attaching to the ankle and pulling the ankle either planar down in the flexion motion, or pulling it up, as in the tibialis anterior here, which is the one in the front, as in dorsiflexion in the motion, which is dorsiflexion in the hand would be extension. And so in the foot, we just, for some reason, use not extension and flexion. We use dorsiflexion as in extension, so to speak, as bringing the foot up, and plantar flexion as in real flexion, pushing the toes down. All right. Anyway, so that's that one. And then we have the lateral and compartment. And the lateral compartment is really cool. Very important when you twist your ankle, because those muscles are attached on the outside by the fibula right here. And they go either to the outside of the foot, or they reach, where is that? They reach underneath and go to the inside, the medial side of the foot. And if I put my finger into here on your foot and you had a twisted ankle, you're going to scream to the ceiling. It's so tender, because these muscles often, they get overstretched if we twist our ankle this way, and then they get really sore. So these muscles are very important because of that stabilization of the foot to the outside. So they don't push the foot in or toes up as much, but they make sure we don't twist the ankle to the outside. That's because when we twist it, they also become hyperactive, because they're going to make up for whatever we tore down here. The ligaments down here, depending on how strong a twist is, a twisted ankle is, they can get torn. Good. All right. That's enough for that. Any questions right now? No? Good. Where are we? Uh-oh, somebody talk to me. Okay, if I don't hear, yeah, go ahead, please.
Oh, I would say that was an accident. Thank you.
Oh, okay. Good. But is this helpful what we're doing, or is this boring?
No, this is perfect.
No, it's helpful.
Okay, good. Then let's go.
Yeah, thank you.
Good, good. No, I'm glad. I'm always afraid I'm, talking too much into you. But let's then go right. I think we should go right into a quiz a little bit, unless you have questions. But it seems like this is pretty straight understanding material at this point. Now, again, I'm more interested in you guys understanding this material than memorizing it. So when we do a quiz right now, which I want to do, and I want you to take out a sheet of paper, I do want you to have the term list in front of you and every other aid you have, because again, on the test, it's an open book test. You can use anything you want. You don't have to worry about me correcting you on that. So let's take out a sheet of paper, and then I want to do that quiz. So first of all, in this test, I ask you three things specifically. I ask you either for a bone, for a landmark on the bone, or for a muscle. And so first, let's talk about asking you for a landmark on the skull bone, as in number one, and that is a bump that's right behind the back of the ear. The bump behind the back of the ear. If you push that, it could be a little tender because it's different type of bone. It's bubbly bone, very porous bone in there. What is that called? Number one. Number two, and again, if I'm too fast, you stop me. I can go back. Number two is when I open the skull up, I have the big hole, the foramen magnum in the back, and then a little forward, this is the front part, I have this indentation where I have a gland sitting in. What is that indentation called? Number two. Number two. Number three. Oh, look, muscles for the face. Let's do a muscle on the face. Number three, when I look at the side of the face, deep inside, not the superficial little sliver, the one deep to that, the one that causes the dimple. What is that muscle called? The dimple muscle. What's the dimple muscle called? Oops, sorry, that was my bad. Number three, that is, right? The dimple muscle. Number four, I want you to give me the muscle that goes around the eye, a round muscle around the eye, please. Number four. Round muscle around the eye. There we go. Round muscle around the eyes, number four. That was easy, huh? Now, number five, let's go back to the bones. I want you, if you look at a general vertebra like here, number five, I want you to tell me the back tip of the vertebra. What's that called? The back tip of the vertebra. Number five. Back tip of the vertebra. Yeah, question?
Can you just repeat that, please? The five.
Five is the, if you look at a generic vertebra, it's the most posterior tip. Like up here on this picture is this part here. That's the same picture as in the column, or so the same way the vertebra is oriented. See that one there? Number five. Number six. We'll go right into, oh yeah. Number six, what is this bone called? The whole bone. Not anything on the bone, the whole bone. Number six. Number seven. On the scapula, I want you to tell me at the tip, at the end of the spine of the scapula, what is that called? The tip of the shoulder. It's a specific name. That's number seven. Specific name, the tip of the shoulder name. And then number eight, when I look further down, not the humerus, but on the all, no, let me see, I can't see that one. On the humerus, what is this indentation here called? That's the back of the humerus on the elbow. So when you extend the elbow, that part of the humerus is where the tip of the elbow goes into. So it's on the back side, an indentation. It's got a kind of an interesting, weird name. That's number eight. And then number nine, we'll go to the hip. And on the hip, when we see these two parts here come together in the front, what is that thing called in the front? That's number 9. Bene, bene. Number 10. Let's do a few muscles. Let's be a little nasty here. Oh, look at that. My computer does not want me to be torturous. The muscles don't show up. There they come. Good. Slowly. Yeah, it's incredible how much space that Zoom takes here. I even opened that before we had class. Come on. Sorry about that. Just give it a couple seconds. If it doesn't show up, I guess we have a slow, an early stop with this quiz, which I hope not. There you come. There we go. All right. So let's hope. All right. Some. Jeez Louise. While we're waiting here, any questions coming up?
Professor, could you repeat number 3 again?
Number 3 is the muscle on the side of the face. That, oh God. I don't know what the problem is. I have to describe it. The pictures don't show up anymore for some reason. There it comes. Very slow. Number 3 is on the side of the face. A muscle that, okay.
You said the dimple?
Yeah, the one that causes a dimple. If that's in the text, I think somewhere. Yeah, I'm really sorry. I'm not sure why this machine is so slow all of a sudden. Let me just really briefly do a couple things. And then if not, we just close it out with that one for some reason. It's even a brand new computer, you would think. All right, let's see if that speeds it up. Take that out too. Close that. All right. Thank you, patience, guys. I'm so sorry. Yeah, it doesn't want to do this Speedy Gonzalez thing. All right, then we just have to do one more thing. And if not, we're not going to worry about it. Test 2. Poor machine is overloaded. I guess I have to go do some sports and not work all day. All right, this might help. Okay, so you were number 3, right? Number 3 is on the side of the face, the deep muscle, not that sliver that's superficial, but the deep muscle goes in the corner of the mouth into the mandible, basically, on the backside. All right.
Okay. Thank you.
And then I think you're gonna go to muscle. Look at that. Now it's giving me some Speedy. Well, that's better stuff. Hey, don't jinx it. Okay, muscle. Look at that. Since we're right here, let's talk about them. Give me the muscle on the side. And what number would that be? Number 10? Is that number 10? Here we go.
Yes.
Number 10 is a muscle on the side of the shoulder that goes around the shoulder from the front to the back and anchors into the side of the arm. That's number 10. Number 11 is the muscle, which this is the arm from the side. So you got the front muscles and the back muscles. I want this back muscle. That's number 11. On this picture, you see from the back. So it's just this whole muscle here. Goes from the shoulder part into the elbow, which you can't see here, but you can see it on this side. That's number 11. It's the muscle on the back of the upper arm. Number 12 is a muscle that is, when you look the shoulder blade from the back, you have a few muscles that are these sit small, these rotator cuff muscles. You see here, you can See the difference between this teres major and then teres minor? But the one I want you is the top one. The top one. That would be number 12. What's that called? Numero 12. Number 13. Let's do some forearm nasties. Let me close this down a little bit so we can see the whole forearm. So this is the forearm on the front side. So this here is the thumb. So this is the medial epicondyle. So it's really weird. It's the left side a little bit. It's weird. The books and the pictures generally use the right side, but for some reason to confuse everybody on the models, they give you the left side. But anyway, that's because of that. But so we have these four muscles here. 1, 2, 3, 4 that we talked about. I would like for you to give me the one on the front here that goes towards the pinky side as number 13. Flexes, oh, it bends the wrist, bends the wrist on the pinky side and travels on the pinky side. Number 13, and then number 14, I talked about one muscle that is actually an arm, an elbow flexor that starts quite high. No, not that, actually it starts higher than we think. On the elbow, on the humerus, and goes down towards the thumb side and attaches about here, not on the wrist yet, but still on the radius. And it's sort of the dividing muscle between the back and the front muscles. I want you to tell me that. It's a long name. And the name talks about where it starts and where it goes to. Number 14. Then we go to the legs. Ready for that? Here we come. The first muscle I want you to tell me is when I look at the butt, the back here, the butt area, this part, top muscle is the gluteus maximus. I take that off. I have one in here, a muscle, that's that other gluteus, but then I have one that goes across here, and it's where the nerve, this is the sciatic nerve where the nerve goes through. I want you to tell me what that muscle is in the back of the iliac fossa, in the back of the, that muscle is number 15. Let's do 2 more. I have one here in the back of the thigh, and I'm going really deep. I understand that these are really deep concepts already, but I want you to take notes, and then I want you to use this quiz and last week's quiz as sort of one of your guidance when you learn this stuff, okay? Because I'm specifically asking you specific questions. But when we look at the hamstrings here in the back, I got 2 hamstrings, one on the outside and 2 on the in. I got 3 hamstrings actually. One on the outside, laterally in here, and then one on the inside. 2 on the inside, sorry. I want you, if you can, tell me the one on the outside, if you can do that. I know this is very deep and it's not even full this week's material, but if you have gone that far, go for it. And if not, just be part of it. And then the last one, but take notes because these are important for the test. And then the last one I want you to tell me is on the quads in the front. We got a muscle on the outside, a top layer, and then a big muscle on the inside. What is the one on the inside called, if you have that? That would be number 17 and the final question, in case you have that already studied a little bit. All right, with that, let's go and solve the quiz. Give me as many answers as you can and speak in, just speak out freely. What is number 1? Anybody? Hello. Uh-oh.
Is this mastoid process?
It is the mastoid process. Very, very good. These are not easy anymore, but you're getting good at it. Now, number 2.
The sella
Yeah, the sella turcica. That is very, very good. Very nice. And again, it's anatomy. You can speak it out the way you want. Somewhere in the world, they got to pronounce it the way you speak it out. So be very free on that. Then we have a muscle here on the side. What was that muscle called?
Buccinator.
Yes, the boxinator. Excellent. Or buccinator. And then the one around the eyeball, number 4.
Orbicularis oculi.
Orbicularis oculi. Excellent. I know I don't have that many people on the call, so if you know it, just speak it out, even if it's always the same. What was that? Number 5, the tip of the spine in the back that you can touch.
Dens.
Spinous process. The dens is this here. When you look at C1 and C2, the round one is C1, the atlas, and that goes over C2, the which is the axis. And the reason why, and this sticking up thing that causes sort of this up and down axis is called the dens. When you look at the generic vertebra, on C2, the spinous process, this back tip would be here. On a regular vertebra, it's this back here behind the body, all the way in the back. On our own bodies, when you touch your spine, it's the tip that you touch. So that's the spinous process. Then what was this bone called? Anyone, please?
Sacrum.
Sacrum. Excellent. Number 6. Good job. And then number 7 is when I follow the spine of the scapula to the tip of the shoulder. What's that?
Acromion.
Acromion process. Very good. That's when people in football often talk about AC injury, acromioclavicular injury. It's this joint here that gets separated. Then I have number 8. Look at the back of the elbow in the back, that indentation here. Anybody?
Olecranon fossa.
Very good. It's the olecranon fossa. Excellent. And then we went right to the hip and we talk about the hip bones coming together in the front. What is that bone? That's joint actually called there. It's a joint.
Pubic symphysis.
The pubic symphysis. Very, very good. That's number 9. And then we go right. Wait, did I skip 10 or do I have a 10? No, I have a 10. We get to the muscles now. Ooh, now I'm getting a little challenging. What's this top muscle here called? Anybody? That's number 11.
Deltoid.
Deltoid. Very, very good. That's the deltoid muscle. And then number 12, we're staying in this shoulder blade, the top muscle in the back of the shoulder blade. Anyone? It's the same name as the area. Remember the fossas? The supraspinous fossa and the infraspinous fossa. The muscle that lays in the supraspinous fossa is called the supraspinatus muscle. The one that lays in the infraspinous fossa is known as the infraspinatus muscle. So that's how you remember those. And then I went into straight nasty here. Forearm muscles. Let's give it a shot. What is number 13? Anyone? This one right here. Did anyone figure that out a little bit?
Thank you.
Try it. No? Flexor carpi towards the pinky ulnaris. The flexor carpi ulnaris. This here would be the flexicarpi radialis. You see, goes to the thumb side. So the way you understand these words is flexor is a forearm in the front. Carpi is the wrist. Varicose is ulnaris or then radialis. The other ones here that are of importance are the pronator teres here and the palmaris longus right in here. And you see that by seeing the tendon going over that white stuff here. That's that flexor retinaculum I was talking about. Okay, then I know these are very challenging, but I want to make sure you learn as much as you can from these. Then the next one was this one that is on top. That actually is an upper arm muscle, an elbow flexor muscle, but reaches all the way to the end of the radius on the thumb side. Anybody have an idea of that? That's number 14.
Extensor carpi radialis.
Yes, almost. That's this one.
Pronator teres.
No, that's this one. Almost. It goes to the upper arm, what we call muscles that have a starting or ending point in the humeral area.
Brachii.
Something brachii, right? So it goes from there on the radius.
Oh, there is brachio.
Brachioradialis. Is that what you said, Sandra?
Yeah.
Yes, that's the right one. So keep that in mind. That brachioradialis, that top muscle here. I'm sorry, the picture is a little cut off because I was just fast taking them, and when COVID started. But that is the topmost muscle here on that extensor side, and that's the brachioradialis. That's very good. That's a tough one. And then I did a couple that, you know, in case you have it done at this point or have some idea already, what is the one in the butt called? The deep lateral rotator, number 15. Yeah.
Piriformis.
Very good. The piriformis. Excellent. And then the next one, challenging. We talked about the hamstrings. The ones on the inside are both named semi. There's a semitendinosus and a semimembranosus. And you'll go through it if you have not, which most likely you haven't yet. Those are on the medial side. On the lateral side, we have one that's called the biceps. Oh, I shouldn't have said that. Did anybody get that? The biceps femoris?
Femoris.
Did you get it?
Yes.
Good job. That's excellent. Did you also get the last one? This one?
Vastus medialis.
Yes, very good. That's excellent. That's, if you haven't caught these yet, this is this week's material, but those are important review questions I want you to go over before you take the test. All of those quiz questions of today and also last week, that will help you greatly when it comes to the test, I believe. All right, so that's pretty good. How you feeling about this stuff? Any comments, questions, fears?
I'm concerned that there's not enough time.
For taking the test or until we conclude the test? Like the end date?
No, the actual test.
The actual timing?
Yes.
What do I give you, 120?
Yes.
What you feel, you need another half hour?
I don't know. It's just that your last test was 75 minutes and it took me about 70, 71. So I'm just nervous about that.
Yeah, I can give you guys another hour.
Yeah.
I don't want you to feel rushed. You know, it's more important for me that you get the material. All right. Yeah, let me change that. I'll give you another hour, then hopefully that should be enough time. I don't want you to worry that the time is a problem.
Yeah, that'll be really helpful, honestly.
Yeah, no, then let's do that. No, I don't need you to worry about that. No, I'm glad you're bringing that up. No, I'm happy to do that. That's not a problem. All right, good. So I'll do that after we're out here. Also, I'm leaving. I got to make sure I change that. I'm leaving the test open till, what did I say? Next Tuesday, I think, right? So it's going to be live from this Friday to the following Friday. Tuesday, it's in there already, but I'll leave it open for a whole week. That way we can go over some stuff again next week because the lower extremities, some of you haven't touched that yet. All right.
Perfect.
Good. Any other questions or comments? You know, the other thing we can do this week, if you want, we can have us a session, the Q&A session. We can have us one of those. If some of you guys want to reach out to me, just go give me a pronto. And that's not a problem at all. All right. Good. If the other thing I wanted to say before we quit is on the grading discussions, if you get 8 points out of 10, just go back and make sure that if somebody gives you a reply back to them to close the circle so they know that you read the stuff. At the end of the semester, you know, I'm going to go check and see the ones who didn't get replies. If you don't get a reply, don't worry about that. I'm going to give you those points. All right. But just keep that dialogue finished up. And then I'm really grateful for getting the evaluation discussions, the posture evaluation discussion. It seems like generally that's an exercise that was helpful from what I read. Is that right? Any comments to that?
Yeah, it was pretty helpful. Definitely showed me areas of I need improvement on.
Okay, yeah, it does to me all the time whenever I review. That's the reason why I'm making this. And also on the injury prevention, a lot of you guys probably are doing that now. You know, go do the best you can. If it hurts or so when you do it, be gentle with yourself, but test yourself. You know, give it a good shot and see what you get out of it. All right. And if you have questions, just reach out to me and we can set up a discussion or whatever we want to do about it. Good. Well, with that, I'm good. Any other questions or comments? Good. Then we can close it out if everything is good. I wish you a wonderful week. Stay in touch, and we'll be doing some more grading today. So don't despair if I haven't done it yet. All right.
Thank you.
All right.
Thanks. Bye.
Bye.
Thank you. Bye.
You. Yeah. If anybody needs to stay, I'll stay around a little bit.